Welcome to the Birth Boot Camp podcast, your trusted guide on your journey through pregnancy, birth, and beyond. I'm Holly, your host, along with Cheryl, Megan, and Liana that make up the Birth Boot Camp headquarters team. Together, we are here to explore the amazing world of childbirth and family wellness. Each week, we'll dive into empowering conversations with expert guests and share practical insights and heartfelt stories to support you on your unique path to parenthood. Whether you're expecting your first baby, you're a seasoned doula or childbirth educator, or simply curious about the miracle of birth, you're in the right place. Together, we'll celebrate the beauty of birth, honor the strength of motherhood, and embrace the joy of new beginnings. So sit back, relax, and join us on the Birth Boot Camp podcast, where every birth is amazing, every family is supported, and every story matters.
Good morning, everybody. Welcome to the Birth Boot Camp podcast. My name is Liana. I am the administrator for Birth Boot Camp.
And I'm Megan Busk, the head of marketing.
Today, we are talking about hospital restrictions that maybe nobody's talking about. So we're talking about things that a lot of times you're not going to know about until you get to that hospital, unless you know to ask these questions ahead of time. And we're going to start off with a big one. And I hear it all the time from people where it's like, oh, my provider, my doctor won't let me eat in labor. So let's discuss.
Yeah, nothing by mouth. No eating and drinking in labor. Now, this began in about 1940 when women who were having C-sections were under general anesthesia. So they had, they were intubated, and the fear was that if they aspirated, that there would be a lot of complications. And so they stopped letting women eat or drink because of that procedure. C-sections have come a long way since 1940, and they're no longer done with general anesthesia. So that's like the biggest difference and why it's not so much of a concern anymore.
Yeah, so the risk was infection, and the biggest risk was death. These policies are still so common, though. The reports that were done in the early 2000s recorded one death caused by aspiration out of more than 6 million births. That's a really low percentage of risk, like in the 0.0s of risk. So, I mean, the discussion is how much do we really need to be pushing this policy anymore? And in my experience, the vast majority of women in labor, after they reach a certain point, they don't even want to eat anymore. Because their body is so focused on labor that it's almost like your stomach is no longer a functioning member of the party, right? It's like, nope, we've got other things going on. So the safety of eating and drinking in labor is, I don't think it's as big of a question anymore.
Yeah, absolutely. And I love that you brought up, like, I'm one of those people, like when I'm in labor, I really like the idea of eating. It's not something that crosses my mind, but being able to at least know that that is an option for you, or whether it's not an option for you, is something that you want to know beforehand. And even I think bringing it up with your provider and just letting them know, like, I know these are the statistics. I would like to eat in labor and plan to eat in labor, and like, this is why, and kind of have that discussion with them prior so that you guys are kind of on the same page. There are, like, oftentimes with my clients and things like that, there is a point where they are just completely depleted in energy. So even if they're not like mentally thinking, oh, I really want to eat, if they can at least get something in their system to help them get through that pushing phase, like, it makes such a world of difference, don't you think?
Yeah, absolutely. And to their credit, recently, the vast majority of nurses that I've met are very much the just don't leave crumbs in the bed. Like, just don't make it obvious that you're eating. It's like the nurses are kind of getting there. They're seeing that it's not as big of a deal as it used to be. But the OBs, and I'm making a big blanket statement, and I know that's not accurate, but most of the OBs are so very concerned about this, and it's probably liability.
Yeah.
But still, do we really need to be pushing this?
Yeah.
I
Well,
had a
and
client.
OBs are like surgeons, right? So that's like their main focus is like, okay, well, when this gets to surgery, then I need to take precautions versus like,
Like,
we're starting at the lowest level and, we're probably not going to get to that point. They're kind of thinking,
absolutely.
they might be thinking about it a little bit backwards than like a midwife per se.
Right. And I mean, that's a whole different discussion, isn't it? About
Yeah,
how
it sure is.
OBs don't, pregnancy is something that needs to be fixed instead of a process
Yeah.
that we are in. It is not you're not going to the hospital to be fixed or cured like an illness or a broken bone. No, this is something that we are doing, and the hospital is there as a safety net. I had a client who, she was eating breakfast. She was having an induction. She was eating a Belgian waffle. She was living her best life. And this new OB came in and just, I would rather you not be eating because of this risk. And I loved her response. And she took the birth boot camp class, the comprehensive. And her response was, well, I would prefer to eat.
Woo!
And I was just cheering in my head so loudly. I was so proud of her for making her statement and being like, I know the risks and I am choosing to fuel my body. This is what I need right now. And the OB was like, well, you finish your breakfast, but then it's going to be only clear liquids. And my client kind of nodded her head like, I'll concede for now, but it was definitely one of those, I'm totally going to push again if I feel the need to eat later on.
Good for her. That is so awesome.
Yeah, well, let's talk about the evidence for eating. We know that fueling our bodies gives us energy, and that's not even talking about pregnancy. We need to eat to have energy. But labor is long, can be long, is usually a decent amount of time. And no matter how long it is hard work. Even if you have an epidural and you're not feeling the pain, your body is still working incredibly hard.
Well, we also have to consider that the uterus is a muscle. And if our muscles aren't being fed, like we know, we can't do hard exercises or things like that if our muscles aren't being fed and they're not hydrated well. So if you expect your uterus to be able to do its job properly, it needs to have the nutrients, all the liquids, all the things that it needs to be able to function properly. So I think that's like the most important thing to remember is that its role as a muscle.
I love that you mentioned that. And it immediately made me think of how we talk about labor as a marathon. And marathon runners, they don't run their marathon without fueling themselves. Like they'll collapse on the side of the road. Do they stop and have a meal? No, but they've got those like gel packets that are chock full of electrolytes and protein, because you need that to keep your muscles working. So I'm really glad you brought that up.
Yeah, absolutely. One thing we haven't really discussed, which I just, in my own personal experience, is the fear behind it. Because there is so many people who are saying you cannot eat and drink during labor. So personally, when I was also like in the hospital in labor, my husband be like, here, just take a bite of this real quick. You're like trying to hide it and you're fearful. And like fear never is great in labor. Like that is just on its whole new cycle. But I think it's just one of those additional things that brings us a little bit of tension and a little bit of fear because it is a restriction that we have.
Yeah, and that autonomy is so important to make it to make it seem like labor is not happening to us, but that is something that we are actively participating in. And you're right, when you're trying to hide the fact that you need to eat and that you are eating, yeah, that can cause some tension. Really good point.
Yeah. Well, I love that conversation because it is so common, and it's just, and the fact that it's number one for us is really important. The next thing we want to talk about is cervical exams. And this is a big one as well, because, and we've talked about this in previous podcasts, we've talked about it in, on our blog, in social media. And the thing that we say a lot is that your cervix is not a crystal ball. It cannot predict what is going to happen with your labor and its progression. And so oftentimes we see that providers, nurses, all these people want to check your cervix throughout the entire laboring process, but it really isn't going to give us an idea of when your baby is going to be here.
Right, especially in a low risk, no intervention labor. There's really no reason to, except to know where you are right now. And knowing or at least suspecting what that number could do to your mental state while you're in labor.
Yeah.
Knowing where you are, is that going to help you? Is that going to be something that sinks your motivation down and make you go, oh no, I've only dilated 1 more centimeter in the last 5 hours? And I always have to remind people that doesn't mean it's going to take you another 5 hours to dilate 1 more centimeter. It does not have any bearing on how the rest of this labor is going to go.
Yeah. Yeah, exactly. I think as a doula, the things that are most important or like most helpful during a cervical exam is to be able to see like baby's position and to be able to see like where their station is, because then it's easier for me to help like guide that process to get baby, out a little bit easier. But even still, I can do my job without that information. You know what I mean? So yeah, there's a lot of things that come with cervical exams. They do check dilation, effacement, station of the baby, position, ripeness of your cervix, all those things. But again, it really is just numbers. So it really doesn't help us in the long run of when that baby's going to be here. And they're uncomfortable. They're not very fun.
Yeah.
So if you're like in a groove and you're like feeling this and you're, you've found your rhythm in labor, and then there's a moment where your provider wants to check your cervix, that can completely throw off how you're feeling. It can throw off your rhythm, and you have to kind of start that process over again, which can sometimes be hard.
Yeah. Headspace is so important in labor. And we talk about how much labor is in your head, and the work to process what you're feeling and the intensity along with the emotions and the hormones. It's not just a body thing, it's a mental and emotional thing too. When I had my home births, I always joke, I'm like, my midwife for my first home birth, she never even saw that part of my body until there was a baby coming out of it.
That's amazing.
She never did any checks. She asked prenatally. She was like, hey, are you going to want me to do any exams? And I was like, no, not unless you think it's necessary, because I trusted her to make that call. But I do also want to bring up and make sure that we are clear that while a non-intervention labor does not need cervical exams, sometimes they are necessary, because a laboring woman with an epidural is not feeling an urge to push, is not feeling transition. And so sometimes cervical exams are important if you are having interventions already done. That way they know what's going on with your body, because you can't express what's going on with your body.
Yeah, I like that you brought that up, because that is so important to understand as well. Absolutely. Yes. So why you also, like, oftentimes when you get to the hospital, they will want to, if you're having a hospital birth, they're going to want to check you because that is part of their admission process. And so, I mean, there are other signs to be able to tell if a woman is in active labor versus their cervical checks. But that's something you're going to want to discuss with your care provider. And I mean, I've met some like CNMs who will say, like, I'm just going to waive that because they can tell whether or not their patient is in active labor. But that's something you'd want to talk about with them beforehand. And if you're really wanting to avoid cervical examinations, then being able to address that prior is something to consider.
Right. Absolutely. Triage. I always hate talking about triage to my clients and explaining to them what it is. Like, if you are not coming into the hospital in roaring active labor, you're stopping in triage first. And the vast majority of hospitals that I have attended births at, they will not admit you if you are not 4 centimeters or better.
Yep. Same.
Or they'll say, we can admit you, but we're going to want to augment your labor to get it moving. And I'm like, why would we do that?
Yeah.
So that's one of the ways that I encourage my clients to wait as long as possible. If you want to avoid that cervical check and having to stop in triage, you wait until you are literally roaring in labor.
Yeah. I can't remember what book it was that I read, but it was talking, I think it was Natural Hospital Birth. And she was talking about, it should take you 20 minutes to get to your car. And if it takes you less than that, then you should stay home because she's basically saying, like, you're not quite there yet. If it takes you like 30 seconds to get to your car, you're probably not in active labor.
Right. Especially for first-time moms, to be clear, who don't know how their body is going to respond to labor. I remember calling the hospital with my 4th delivery, and you have to call ahead so that they know if they want you to stop in the office first or if they're just going to admit you. And I was able to talk pretty well through contractions, but I also know how I labor, and I'm able to talk through my contractions for quite a long time. And she was like, well, I think we'll have you stop in the office. And I said, this is my 4th baby. I need to be admitted by the time we get there. It's going to take us a half an hour to get there.
Yeah.
And she was like, your 4th? I was like, yes. And she was like, great, I'll let them know.
That's amazing.
I've been here before. I know what my body's doing here.
That's hilarious.
So yeah. Oh man. Okay, so let's talk about monitoring. In our classes, we talk about trying to avoid continuous monitoring. When they first started doing continuous monitoring, I don't know when that was, the 80s, 70s, 80s, they started doing that, thinking that, and I mean, you'd think this would have been the right move. Doing continuous monitoring would be able to catch things and save moms, save babies. And instead, what happened is they were over-diagnosing problems, and the C-section rates and intervention rates were going up, but they weren't necessarily saving more moms and babies. That rate didn't change, just the rates of surgery went up. And I don't have that data on me, but I remember hearing that in one of the documentaries about how that was such a huge issue. So instead, we have intermittent fetal monitoring. What do you see in the hospitals where you are, Megan?
As far as intermittent, I would say they're not so intermittent. You know what I mean? Like, they say, oh, we're just going to leave this on for 20 minutes, and then they never come back. Or, you know what I mean? Like, I very rarely have seen where a fetal monitor was removed for a duration of time. And same with me. all of my labors, I had continuous fetal monitoring.
Wow.
Yeah.
Yeah.
So I think I find it fascinating because they do tell you, yeah, it's just going to be for, 15, 20 minutes. And then it's there for the rest of your labor. And that could be, I've had one nurse who said, well, there was meconium present in the water's broken. And so they just had that continual fetal monitoring. And so I don't know if that's like the common theme that I'm seeing. But yeah, most births that I go to are usually like continuous, which is unfortunate.
Yeah. I definitely see the logic though in if you know that meconium's present.
Yes, absolutely.
I definitely understand that. Yeah, that seems to be the really common compromise for monitoring here in Denver is 20 minutes on, and then they'll let you be a few hours. Though they are
That's
better
nice.
about actually, they're better than apparently your hospitals because they'll actually do it. And if they forget, I've had clients who will call, like they'll push the nurse button and be like, hey, it's been 25 minutes. I'd like this off of me now.
Yeah. Yeah.
I'm ready to move around. I'm ready to do what I need to do. With wireless monitoring, it's almost trickier because they're like, oh yeah, you can move around all you want, even with the monitor. And so the argument of I want to move around, you can't use that anymore. But it's not like monitors are comfortable.
No, not at all. And like, so you have there's monitors that there's two, one for you and one for baby, and they strap a piece of fabric around your entire body and your belly, and this monitor just kind of gets pressed into your belly, and it's kind of uncomfortable. Because it's pressure, where you already have pressure, it's just not fun. And then they have the wireless monitors. Those are wired monitors. The wireless monitors are actually stuck onto your body with like an adhesive almost. It's like sticky, and it sticks right onto your belly. And that, I mean, that can be uncomfortable too. And because it is sticky and it's stuck to you, do you find that that's usually just left on? I mean, like I said, my experiences, they usually are, but I feel like once the wireless monitor is placed, they're usually it's just there,
That's interesting. So I've seen two kinds of wireless monitors here. One of them is the sticky kind, but I've also seen ones that look just like the wired ones. They're like that thick disc that they place on your belly. It's just not wired.
Oh, cool.
But it's the same elastic straps that they wrap around you. So my thing is how often they have to readjust that monitor though, because baby's moving.
Yes.
So then it's like, it's really making your life easier as a nurse to just not have to keep adjusting those monitors.
Yeah.
Right? Like you're going to have to keep coming in here because I'm moving.
Yeah.
So
I'm going to be all over. So baby's going to be all over the place.
Exactly. I've seen in the birth centers, they won't even do the actual monitors, like the 20-minute monitoring. They'll do, excuse me, they'll do what the home birth midwives do, and they'll have the Doppler.
Yep, Doppler.
Just do the handheld Doppler, and they'll hold it there for 30 seconds to a minute just so that they can do a count of baby's pulse. And then they're done. And I'm like, why can't we just do that, everybody?
Yeah, right? It seems a lot more simple. It just does. Maybe because you have to, they want it for 15, 20 minutes in a hospital. They're not going to stand there with a Doppler for 15 or 20 minutes, So yeah, that is really interesting. But it's just so much less invasive, I feel like.
Yeah. And people think invasive is an internal thing, but invasive can mean just your body and your personal space.
Yeah, your bubble.
Having these extra things on you is distracting. At a minimum, it's distracting. But then uncomfortable and it's potentially painful during contractions. Because like you said, it's still pressure against your body. And when that uterus is contracting, that muscle is contracting, having something squeezing it or pushing against it doesn't feel good.
Yeah.
And aside from that, there aren't a whole lot of benefits to continuous monitoring,
Yeah.
unless, as before talking about cervical exams, unless you are having interventions done. If you need pitocin or you need the epidural, this is where monitoring is very important, because they want to make sure that baby is not reacting poorly to the medications.
Mm-hmm. I really like that you bring that up, because most of these things that we're talking about are for very low risk, unmedicated labors that are occurring. So just knowing that, like, as interventions happen, yes, there are going to be things that are going to be more necessary. So I think that's really great. And we just recommend talking to your care provider about what intermittent monitoring looks like for them, and if there's room for compromise, and how that all is going to work out. And we'll add a list of questions that you can ask your care provider about all of these. We'll add these down in the comments as well.
Even better, take a class so you know
Even better.
what to
Take a
ask,
comprehensive childbirth class.
because we can't tell you what your specific provider or hospital is going to do. We can just tell you what the evidence and research is suggesting. And you have to be the one to ask those questions of your provider. So taking a class that is not provided by the hospital is really important, so that you can get the right information to ask all the questions.
Yes, absolutely. That is perfect. So let's talk about laboring in the water. Does your hospital or birth center, do they have a birth tub? And what does that look like for you as a laboring person? Now, hospitals are going to have much different policies than a birth center, or obviously your home. And hospital births tend to, if they do have a pool or a laboring tub, if they do have a birth tub for you, there are going to be specific things that they will or won't do. A lot of hospitals are not going to let you push in the water. Some will, but I feel like they're few and far between.
Yeah, we have one hospital in the Denver area that lets you deliver in the tub, but then of course you have to get out right away.
Yep. Yeah.
Which is
Because they
not
don't want
fun.
you to deliver your placenta in the tub. Yeah.
Right. And even most home birth midwives and birth centers want you out pretty quick too, because
Yep.
while they can gauge initial blood loss in the tub, they can't tell if you are continuing to bleed, and it's important for them to be able to take stock of that. The big thing about laboring in the tub is we're gonna track back to those monitors. And can you even have monitors on in the tub? Because Megan, you mentioned that monitoring, it doesn't necessarily mean it's intermittent. Like they're gonna leave it on you even if they say they'll do intermittent. So what does that mean for your ability to be in the tub?
Yeah. And all monitors are different. But I recently attended a birth in the hospital, and she wanted to labor in the tub. But her specific monitor, even though it was waterproof, so they say, they wouldn't let her submerge it in the water. So I think it was more like water resistant. And because it was placed so low on her belly, like the highest she was able to get in the water was just below her belly, which is not really terribly helpful. Like, the goal of getting in the tub is to relieve some of the pressure of your body. And like, we always talk about, like, at least submersing your belly in the water, because that is what's helpful. That is why laboring in a tub is so helpful. So like she got in and she was like, what is even the point? I can't, like, my legs are wet. How is that helping me?
Yeah.
And so I just think that being able to, even if you like take a tour of your birth space and like ask that question, like, how high are you going to let me fill this tub? How are you going to let me get all the way in? How deep I want to get in? You know, asking questions so that you know what to expect when you get to that point.
Absolutely. Absolutely. Because we are very pro laboring in the tub if that is something that you want to do.
Yeah.
We call it the midwife's epidural for a reason, because it's effective. And
Mhm.
again, a blanket statement that may not be accurate for everybody, but more often than not, I see water really helping the
Mhm.
intensity of contractions.
Yeah, especially as you get into transition and like that can be a tough time. And so water is so beneficial and can really help during that time for sure. So yeah, asking all the questions and making sure you know what you can and can't do with laboring in the water for sure. Um, Another thing that you will want to consider is like lactation consultant services. So there are usually in most hospitals, they do have a lactation consultant who comes in and will discuss with you different ways that you can hold baby and different concerns that may arise and things that you just want to kind of look out for. But you want to know if they actually are available. Like, are they only working 9 to 5? Like, if you have your baby at 1 a.m., are they going to be able to be there and talk with you about all of those issues?
Right. And I mean, sometimes babies don't want to nurse until after an hour or two. Sometimes babies are tired. But still, like you said, if you deliver at 1 in the morning, even accounting for that, you're looking at 3 in the morning. You're still looking at hours before potentially a lactation consultant can come in.
Mm-hmm.
Um, and that's just something to know. That's something to ask your hospital to say, what are the hours for your lactation consultants? Because while baby nurses are usually pretty good at helping that latch, if you don't have a doula that can help you with that latch, unless there is an IBCLC on staff, the rest of us are not able to diagnose anything that could be causing problems.
Mm-hmm.
Even if we saw something that was like, I don't really like the look of that latch, the most that a doula, in terms of scope of practice, the most that we are really able to say is, I don't think that this is right, and you need to see an IBCLC.
Mm-hmm. Yeah, absolutely. I would love to see it where like an IVCLC comes into your room after baby is born, checks on latch, talks to you about maybe different things you can try, and then leaves and lets you just practice it, and then comes back the next day and talks to you about all the other things,
Right.
all the other extra things, so that you can have that time to like bond with baby. And one thing I recently learned is that not all lactation consultants at hospitals are technically trained. They might just be like the head nurse that's coming in and they're on the lactation team, but they actually may not have certifications. So maybe that's something you want to look into as well.
Mhm. Yeah, I know when I had my first baby, gosh, 12 and a half years ago. uh, uh,
I know, right?
I,
It's
I
hard.
remember them saying, okay, the lactation consultant is going to come in. And that's when I found out that she was a nurse who had lactation training.
Mm-hmm.
She was not an IBCLC. Granted, I didn't really know the difference at that time. And in hindsight, I learned that the advice I got was not great advice. But the biggest thing is that it wasn't supportive advice,
Mm.
if that makes sense. Like
Yeah.
she did say the latch wasn't good and here's how we fix it, but she wasn't like, here is how we keep working on this latch. She was not supportive in her instruction. It was just fix it, keep trying.
Yeah.
And it did not make me feel good about wanting to keep trying. It made me feel like I wasn't doing it right.
Yeah.
And that's not a good feeling when you've just pushed out a baby
Yeah.
and you're, recovering from a bit of physical trauma that happened.
Yeah.
So yeah, and also even IBCLCs are not the same across the board. And I've seen this at different hospitals here in Denver where a team of IBCLCs either could not or would not diagnose a tongue tie in one of my clients' babies. And it
Mhm.
took her calling me in tears because she was bleeding for me to be like, oh my gosh, we need to get somebody to you right away. And so I gave her some referrals because how come this team of IBCLCs at this hospital didn't diagnose this when it
Mhm.
it should have been pretty obvious if she had that much trauma to her nipples already. Whereas at other hospitals, the IBCLCs are so attentive and so helpful and come in multiple times. And even when things are going great, are going, okay, well, let's take a look in their mouth again just to make sure. Even though you're
Mhm.
not feeling pain, let's make sure that everything is great. So not every IBCLC is created equal in the
Yeah.
sense of what they're going to notice. And we see that with everybody. We're humans, right?
Mhm.
So it's remembering that you can always ask for second opinions. And I mean, in terms of lactation, if you are feeling pain, get another opinion.
Yeah, absolutely. And an outside hospital opinion,
Right.
preferably. Yeah, it's interesting because I think here where I live, I think it's just policy because it's a hospital and it's a lot of our hospitals are in the same network. And so there's certain things that IBCLCs who are in the hospital are not allowed to discuss with the patients.
Hmm.
And so always, always look for a second opinion, especially for things like tongue ties and lip ties, because just being able to get out of that policy driven area and finding maybe somebody outside of that to be able to give you additional advice is helpful.
Yeah. And then there's a website, I think it's Lactation Network. Don't quote me on that. Maybe we'll add it to our links here, but that actually pre-qualifies your insurance and finds you an IBCLC that is in your network so that you can get somebody right away. And it takes a lot of the legwork out of finding an IBCLC who can help you that is under your insurance plan so that you maybe won't have to pay out of pocket.
That's awesome. That's a great resource. Yeah, we'll include that for sure.
Yeah.
Okay, so the last thing we want to talk about is, does your birthing location have tools and gadgets and things that you can use to be able to help yourself through labor? So things like birthing balls, birth stools, peanut balls. A lot of hospital beds have a squat bar that is available. So just knowing what is available to you is super important. And it's just one of those things that's super easy to ask, especially if you are doing a tour of your location. But like, are they going to be readily available is important to know.
Yeah, that last thing you said is what I want to emphasize is it readily available? Do you have to go hunt someone down to find out what closet the peanut balls are stored in? Like, or
Mhm.
are they in the room, or are they just in a closet outside because there's no room in the actual labor room? Whatever the case may be, is it readily available, or do you have to jump through hoops just to
Yeah,
have these tools?
yeah.
And while
And
that's not necessarily a hospital, restriction or standard, I still think it's worth mentioning.
yeah, exactly. And as someone, I'm very tall, and so like there are different sizes of these things as well. So I would check with them and see, like, is there going to be a size that's going to fit my body, and are they upkept? Are they going to be like, I'm going to sit on it and sink to the floor? Like, are they blown up? Things like that. Because most locations, I don't know, but I assume they have like a one size fits all kind of a situation, because I've never been asked like, oh, like what size do you think you need,
Right.
and maybe they can just tell. And that's why I'm not being asked. But for me personally, like they probably don't carry all the sizes. So maybe that's something to look into as well. If you're really a small person or a large person, or, being able to have that knowledge is important too.
Yeah. I had a client who is 4'11", and so very petite.
Yeah.
And yeah, they had what looked like just a standard birth ball that my 5'8" frame could use. And
Mm-hmm.
that's a lot of height difference.
Yeah, it is.
Yeah. And so what ended up happening is we ended up just letting some of the air out so that she could sink a little bit lower, because you don't want it deflated, because then it's not so
it's not helping you.
But in the case of taller people, I mean, there's not really much else you can do.
Mm-hmm.
Like you can't blow it up further because that's not safe.
No. Yeah.
I think peanut balls, it's less of an issue because it's a peanut ball. That doesn't necessarily have anything to do with height. You're just usually propping your
But
knees
leg
open.
length, actually, it does.
That's true.
Yeah.
That's true. Yeah. Yeah, that's a good point.
Yeah.
That is a very good point.
So yeah, things to think about and consider. Not restrictions, but maybe if they don't have your size, maybe that is a restriction. So
Yeah. I'm just glad that the days where I had to carry my birth ball in are done.
Yeah. Yes.
When I first became a doula, it was like 2018, I carried a birth ball in because there was no guarantee that there would be one available, because sometimes they only had one birth ball on the entire floor.
Yeah.
Crazy.
It just goes to show that as we are more vocal about what we want as women, and as we talk about these things and request them, that they are going to realize, oh, like maybe we should start offering this. And that is just, especially with all of these restrictions, the more we ask, the more we talk about it, the more we bring it up as women in the birth world, and talk to them about our care providers. We're going to be, little bug in their ear, and we're going to be making changes. And it might be slow, but they will come.
Yep. Because I mean, we've seen even statements by ACOG, the American Congress of Obstetrics and Gynecology, even their statements, it takes years to trickle down and to actually change hospital policy. Yeah. So for those of us who are, boots on the ground, we're in it. Sometimes we have to be the ones making those demands and saying, no, your own body of whatever they call it, the certifying body that tells you what to do, even they say that this is positive change. And sometimes they don't pay attention, and it's not until clients, patients, doulas, childbirth educators, those of us who are here need to start being the voice.
Yep. Exactly.
All right. I think that wraps it up for us today. Let us know in the comments if you see any other hospital restrictions that we didn't talk about that you want to know more about. Maybe we'll have another one if we get enough comments. We'll do another episode if we need to. Thanks for joining us, and we look forward to our next podcast.
Thank you for tuning in to this episode of the Birth Boot Camp podcast. We're so grateful to have you as a part of our community. If you enjoyed today's episode and found it valuable, we'd love to hear from you. Please take a moment to leave us a review on your favorite podcast platform. Your feedback helps us improve and reach more families on their journey through pregnancy and birth. As a token of our appreciation, we're excited to offer you our exclusive birth plan blueprint. Inside, you'll find expert guidance and a template to help you create a birth plan that reflects your preferences and desires for your birthing experience. Simply click the link below in the episode description to have your blueprint sent right to your inbox. Remember, your birth plan is a powerful tool for communication and advocacy during labor and delivery. Don't miss this opportunity to take control of your birthing experience and advocate for the birth you envision. Thank you again for listening. Be sure to subscribe, and we look forward to sharing more amazing insights and stories with you in our next episode.